Hello and good morning. And today we are going to do cardiology, EKG, and rhythm disturbances. We'll do the EKG features of different rhythm disturbances, the conduction pathway, and the conduction defects. We'll do the features of the PQRST, normal and abnormal P waves, and QRS, narrow complex and wide complexes. And also we'll do other things that VTAC and supraventricular tachycardia and the block and left ventricular and the right ventricular block. So in this we'll do the P wave, we'll do is normal P wave, absent P wave, amplitude increase or decrease, P wave amplitude, and in the other P waves we will do the fibrillary P waves, sawtooth and variable. The variable includes the premature atrial contractions and multifocal atrial tachycardia. So after doing the normal P wave, we'll do the absent P wave. The absent P wave causes are SNOid block, sick sinus syndrome, triple S syndrome, or nodal or the junctional rhythm, idioventricular rhythm, premature ventricular contraction, VTAC, and ventricular fibrillation. So these are the causes of absent P wave when it is not present on the EKG. The SI node block, nodal rhythm, idioventricular rhythm, PVCs, VTAC, and VFib. In the P wave with increased amplitude, we'll do the right atrial hypertrophy, left atrial hypertrophy, and hypokalemia. These are the causes of increased P wave amplitude, right and left atrial hypertrophy, and hypokalemia. And a P wave with a decreased amplitude will decrease hyperkalemia. In the other P wave shapes, we'll do fibrillary or sawtooth wave, premature atrial contraction, as I already explained, and multifocal atrial tachycardia. In a QRS, there are two types, narrow QRS and wide QRS. In the narrow QRS, it's divided into two, physiological and pathological narrow QRS. The physiological narrow QRS, we have bradycardia, tachycardia. It occurs in exercise and in children. Whereas pathological narrow QRS may have a regular rhythm or an irregular rhythm. Both bradycardia and tachycardia are also included in the narrow pathological regular QRS, and also included in them is the first degree block, the nodal rhythm, AVNRT, atrioventricular nodal reentrant tachycardia, atrial flutter, cardiac tamponade, and acute lung conditions. These are the conditions that cause narrow regular QRS rhythm. In an irregular narrow pathological QRS, we have sinus arrhythmia, premature atrial contraction, multifocal atrial tachycardia, second and third degree block, atrial fibrillation, which is the most common cause of irregular rhythm, and atrial flutter with atrioventricular block. Then in the wide complex QRS, we have, let me see what happened to this. Allah. In the wide complex QRS, we have slow to normal rate wide complex QRS, and that includes heart block, idioventricular rhythm, and premature ventricular contraction. In the wide complex fast or wide complex tachycardia, fast heart rate, we have regular rhythm and irregular rhythm. In the wide complex QRS regular rhythm, we have ventricular tachycardia, the monomorphic type. SVT, supraventricular tachycardia with aberrancy, atrial flutter, hyperkalemia, and drugs. And in the white complex, irregular tachycardia, we have atrial flutter plus AVB, atrial flutter plus Wolff Parkinson White syndrome, atrial flutter with aberrancy, Brugada syndrome, catecholamines, other drugs, TDP, torsidipontis, and VTEC polymorph type we have in irregular white complex tachycardia, whereas we had VTEC monomorphic in regular rhythm. And then we have ventricular fibrillation also in wide QRS complex. So before we start doing all these stuff, we'll uh, we'll start with the pacemaker tissues, where are they located and how they function and their action potential generation. The main pacemaker tissue is the SA node. And where is the SA node? It is in the upper posterior wall of the right atrium below the opening of the superior vena cava. And where is the second one is the AV node, other pacemaker, and this one is also situated in the atrium but in the bottom part of the atrium of the right atrium. So both SA node and AV node are situated in the right atrium. And how the impulse is spread from the SA node? SA node impulse continues directly or stimulates directly to the atria and is connected to the AV node to conduct impulse to the ventricle. There are three nodal pathways that connect SA node to the AV node: the anterior Bachman, middle Vanquibax, and posterior Toral. And after the AV node, we have this bundle of his that arises from the AV node. They divides into two, right bundle branch and the left bundle branch. So the right bundle branch supplies through the Purkinje tissue supplies the right ventricle, and the left bundle branch divides into two, left anterior and the left posterior fasciculus. And then through the Purkinje tissues, it supplies the left ventricle. So the speed of conduction is different in different parts of the conduction pathway. Its SA node is 1 meter per second, but AV node is much smaller than the SA node. So its speed of conduction is slow because it's small and it has few gap junctions. So what's the advantage of delaying of the impulse in the AV node? It allows the ventricles to be filled up with the blood that is entering into the ventricle from the atria. So this is the advantage of delaying the impulse in the SA node. So the speed of conduction is 1 meter here and half a meter, 0.5 meter per second is in the AV node, and then in the bundle of his and the right and left bundle it's 1 meter per second, and the fastest speed of conduction is in the Purkinje tissue, which is 4 meter per second. Okay, let's see. Then the action potential in the SA node, there is a stage 4, then it's a resting membrane potential in the SA node is minus 60, and there is a slow depolarization. And when it reaches about 40 millivolts, minus 40 millivolts, there is a rapid depolarization with and the phase 0, and then repolarization with the phase 3, and then again depolarization with the phase 4, and it continues one after the other. And this rate discharges this at the rate of 60 to 100 beats a minute. Then from there, it's okay. Then the impulse spreads to the ventricle. In the ventricular muscles, the resting membrane potential is minus 80 millivolts. And then when it reaches a final minus 50 millivolt, then there is a rapid depolarization. This is phase 0, which corresponds to the QRS of the cardiac cycle. And this lasts for zero point 0.1 to 1 2 seconds. And then there is a plateau phase, phase 2, where the calcium enters, and this lasts for 0.33 seconds. So, and this is repolarization. So, depolarization is QRS and repolarization is phase 2. So, the QRS plus ST is total ventricular depolarization and repolarization, that is total QT interval, which is 0.45 seconds. I repeat here that QRS is 0.12 seconds, the ST segment isoelectric line is 0.33 seconds, and both of them combined depolarization plus repolarization is 0.45 seconds, which is a QT interval. So this is the ST segment corresponding with the phase 2, and phase 0 is QRS, and phase 3 is a T wave. Now in the phase 4, in the phase 0, we have sodium entry. Then phase 1, different elements going in and out of the cell. In the phase 1, we have potassium and chloride out. In phase 2, calcium in, potassium out. And in phase 3, we have potassium out and then restoring the normal resting membrane potential in the phase 4. So if you notice that every time potassium is out in the phase 1, 2, and 3, whereas calcium is in phase 2 and sodium is in phase 0. So these are the different phases of the action potential and the sodium potassium entry and exit into the cell. Then that I discussed this one. QRS we discussed 0.1 second, ST is 0.32 seconds, and ST is QRS plus ST is ventricular depolarization plus repolarization, which is 0.45 second as a QT interval. And then we have the cardiac cycle. The cardiac cycle depends on the heart rate, duration of the cardiac cycle. On a heart rate of 75, the cardiac cycle is that of 0.8 second and diastole is 0.53 second. But if the heart rate is increased to 200, then the cardiac cycle goes down to zero point 0.3 seconds and the diastole goes down to 0.12 seconds. So the duration of the cardiac cycle depends on the heart rate. 0.8 second when the heart rate is 75 and 0.3 second when the heart rate is 200. Now counting the heart rate, regular and irregular. Before that, we discussed the horizontal and vertical horizon of the EKG strip. 1 second EKG strip contains 5 medium squares. So each medium square contains 5 smallest square. So in this 1 second strip, each medium square is 0.2 seconds because 1 divided by 5 gives 0.2 seconds. And then this 0.2 second medium square has 5 smallest square. So 0.2 second divided by 5 gives a 0.04 seconds for this smallest square here. So the smallest square is 0.04 seconds, the medium square is 0.2 seconds, and the big square that contains 5 medium square is 1 second horizontally. But and vertically, the smallest square is zero point 0.1 millivolt. It gives you the voltage vertical horizon, and two smallest square is zero point 0.2 millivolts, and 10 small square makes 1 millivolt. So if you see here, P, duration of P is 3 smallest square, almost 3. So it's zero point 0.1 to 0.12 seconds, and its height is voltage is 2 smallest square, that is zero point 0.2 millivolt. Whereas QRS is similarly zero point 0.1 to 0.12 seconds, and ST, the isoelectric line, is 0.45 seconds here. This is QT interval from here Q to T, QT interval 0.45 4 5 seconds. Then we go to the heart rate count, regular rate and the irregular rate. In a regular rate, we have this number 300 divided by the number of squares between the two R's. So if you see the two R, in between them there are four squares. So 300 divided by 4 gives a rate of 75 beats a minute. If there were five squares, then the rate would be 60. And if there are only one square in between the two R's, then 300 divided by 1 will be 300 heart rate. So this was the regular heart count. In the irregular heart count, we have 10-second strip and 6-second strip. Count the number of hours in a 10-second strip, multiplied it with the 6, and count the number of hours in a 6-second strip and multiply it with 10. So if in the 10-second strip we divide, there are 14 QRS here, multiplied by 6 gives 84 heart rate, and in a 6-second strip, which is multiplied by 10, where we have almost 8 QRS, so the rate is also almost 84. But if the rate is very fast, then 1500 is divided by smallest QRS boxes in between the R's. Then we have leads, the types of lead, two types of leads, chest leads and limb leads. Limb leads are of two types, unipolar and a bipolar lead. Unipolar lead has one electrode. Bipolar leads have two electrodes. AVR, AVL, and AVF are the unipolar leads. And the bipolar leads, which contain two electrodes, are long lead 1, long lead 2, and long lead 3. So these are the six limb leads, three unipolar and three bipolar. Whereas we have the chest lead also, six chest leads, V1, 2, 3, 4, 5, 6. The V1 and chest lead V2 are the septal leads. Chest lead 3 and 4 are the anterior leads, and chest lead V5 and V6 are the lateral leads. The position of the chest lead is that chest lead V1 is the only one which is on the right side of the chest to the right of the sternum in the fourth intercostal space. Chest lead V2 is in the fourth intercostal space, but in the left of the sternum. Chest lead 4 is in the mid clavicular line in the fifth intercostal space. Chest lead 5 is in the fifth intercostal space in the anterior axillary line, and chest lead 6 is in the mid axillary line in the fifth intercostal space. The shapes of the different PQRST in the chest lead is here like this. S lead is more in the anterior chest lead than the R, and the R lead is more in the R is more than S in the left-sided lead, and R is tallest in the chest lead 5. So these are the different leads. Then we start with the P wave, the normal P wave, absent P wave, the amplitude, increase or decrease, and we'll discuss other P waves, the fibrillary, sawtooth, and variable wave. Sorry. So the P wave, what's the normal position of the P wave? If you see here, P wave is upright in long lead 1, 2, 3, and AVF, and all the chest leads, V1 to V6, is upright. The only lead where P wave is inverted or negative is AVR. In AVR, S lead, S is also negative and T is also negative. A lead which is negative, what does it indicate? It indicates that the impulse is going away from the electrode. And an upright lead means the impulse is going towards the electrode. Also in AVL, the P wave is variable. So AVR is negative and AVL is negative. What are the conditions when we have a positive P wave in AVR? A positive P wave in AVR occur in ectopic pacemaker, and number two in dextrocardia, where we can see a positive P wave. Also in long lead 2, the P wave is normally upright, but it may be inverted in ectopic pacemaker. So this is the normal P wave configuration in different leads, and then we go to the absent P wave. So we did the normal, the duration is 0.12 seconds, and the amplitude is 0.2 millivolt, as I already discussed. P wave negative in AVR and variable in AVL, and P wave positive in AVR in ectopic pacemaker and dextrocardia, and also in long lead 2 negative in ectopic pacemaker. See here, long lead 2 ectopic pacemaker, P wave is inverted negative. So this is P wave inverted in long lead 2, and there is a spike before the when they have a uh, pacemaker. Then we have the next absent P wave. Absent P wave occur in the SA node block, 6 sinus syndrome, nodal rhythm, junctional rhythm, idioventricular rhythm, premature ventricular contraction, ventricular tachycardia, and ventricular fibrillation. Let's see the triple S syndrome. This is the sinus arrest. Here, there is no impulse here. This is normal here, and then there is a missing it. Completely absence of the SA node, complete external block, and this should occur for at least for 3 seconds. Then the next one is nodal or the junctional rhythm. You see, the upper one is the sinus rhythm in which all the components of the complex are present, PQRST. But in this bottom one is the nodal or the junctional rhythm, like here, but there's a P is absent. Absent P in the nodal or junctional rhythm. And why it's absent? Because the nodal or junctional rhythm arises from the AV node. And the rate is also slow because it rises from the AV node, and normal impulse generation from the AV node is 40 to 60 beats per minute. So the rate is regular in the junctional rhythm. See, it's regular. Rate is 40 to 60, slow, right? Because it arises from the AV node, but its rhythm is regular. P wave is absent. QRS is contracted less than 0.12 second. So this is the nodal or the junctional rhythm. Then we have the idioventricular rhythm. Idioventricular rhythm in which the normal conduction fails, so that the impulse it arises in the ventricular muscles itself due to intrinsic automaticity of the cardiac myocytes. So this is complete failure in the normal conduction pathway. So, and there are two types of the idioventricular rhythm: a regular one and an accelerated one. In the regular one, the rate is 20 to 40 beats a minute, but it may be as low as 15 beats a minute. Whereas in accelerated one, the rate is 40 to 100 beats a minute. In the idioventricular rhythm, we have absent P wave. We are discussing the absent P wave. We had these two before this, the six sinus syndrome, absent P wave, nodal or junctional rhythm, absent P wave, and now the third one, idioventricular rhythm. P absent, right? The rate is slow because the ventricular myocardium they discharge at a slower rate, maybe 20 to 40. And the two types, accelerated one and the regular one. And when does this occur? Idioventricular rhythm occurs in end stage cardiac disease and in digitalis toxicity. But but it also occurs in successful treatment for the thrombolytic therapy in acute myocardial infarction. So, what's the difference of idioventricular rhythm with the VTAC, ventricular tachycardia? The only difference is that of the rate. So, the rate is slower here. but in VTAC, it's fast. Next is, let me check the things over here. Give a pin. Okay, let's pin it. I can't pin it. Anyway, let's see here. Okay, I pin it. Uh, Okay, let me go back. Hang on a second. Then we have premature ventricular contraction, absent P wave, fourth cause of. And why P wave is absent? Because premature ventricular contraction here, it arises from the ventricle, right? So it's a premature ventricular contraction where P is absent here and QRS is contracted, maybe wide, and the T is opposite the QRS. S is also opposite the QRS. Then the next cause of absent P wave is ventricular tachycardia. This is ventricular tachycardia here. There are two types. Both of them, P wave is absent. This one is monomorphic and this one is polymorphic VTAC. In monomorphic VTAC, the QRS rhythm is regular, dead regular. P is absent, but QRS complexes are wide and the rhythm is regular. Rate is fast, of course, VTAC, and then more than 100. And then this is the polymorph on the right side, polymorph ventricular tachycardia, in which the QR, P absent also, and QRS are wide and irregular, and they vary from beat to beat. So these conditions, I will discuss this VTAC in detail later on. Then we have ventricular fibrillation. Here, the ventricular rate is fastest, 350 to 600 beats a minute. The fibrillation, whether atrial or ventricular, has the fastest heart rate. In atrial fibrillation, we have P wave, which is 350 to 600 a minute, whereas in ventricular fibrillation, we have QRS, fibrillary QRS waves, very wide and irregular, P absent, 350 to 600 beats a minute. So this is ventricular fibrillation compared to the ventricular tachycardia QRS fibrillary. Then we have P wave amplitude, increase amplitude or decrease P wave amplitude. Increased P wave amplitude occur in right atrial hypertrophy, left atrial hypertrophy, and hypokalemia, whereas decreased P wave amplitude occur in hyperkalemia. So this P wave amplitude that is increased occurs in right atrial hypertrophy and the left atrial hypertrophy. The right atrium is more related functionally to the pulmonary system. So the defect is known as P pulmonale also. And the mnemonics, the causes of the mnemonics that cause right atrial hypertrophy are A, B, C, D. B is in blue and not in the mnemonics. So A for congenital heart diseases, ASD, acyanotic congenital heart disease. C for cor pulmonale, D for dilated cardiomyopathy, and E for Ebstein anomaly. So these are the causes of right atrial hypertrophy. So how is EKG in right atrial hypertrophy? Like this one, tall peak T wave. Let me show you this one, tall T wave. This is the EKG of the right atrial hypertrophy. Right atrial hypertrophy. P wave is tall peak, whereas if you see the left atrial hypertrophy, we have biphasic P wave. So this occurs in, so the causes of right atrial hypertrophy are A, B, C, D, E. A for ASD, which is acyanotic congenital heart diseases. The other two, acyanotic congenital heart diseases, they are included in the left atrial hypertrophy. So causes again ASD, B for B is nothing there, C for col pulmonale, D for dilated cardiomyopathy, and E for Ebstein anomaly, and this is P pulmonale or right atrial hypertrophy, tall peak T wave with a voltage of more than 2.5. Here we go next to the left atrial hypertrophy. Left atrial hypertrophy. So, this was the right atrial hypertrophy. I already explained it to you. And it also occurs in pulmonary hypertension and other COPDs, um, chronic obstructive pulmonary diseases. So, the normal pressure, what's the normal pressure in pulmonary hypertension? Normal pulmonary pressure is 10 to 20 millivolts. But in mild pulmonary hypertension is 35 to 60 millivolts. And in moderate pulmonary hypertension is 70, and in more than 70 is severe pulmonary hypertension. Then let's see. Then we go to the left atrial hypertrophy, which is known as P mitrale, because the left atrium is functionally more related to the left ventricle and the mitral valve. So the causes are congenital and acquired. And we see this biphasic P wave, which is known as P mitrale because it's more related to the mitral valve. And these are the causes of the left atrial hypertrophy. Acquired congenital causes, acyanotic congenital heart diseases, VSD, and PDA. The ASD occurs in it causes right atrial hypertrophy, whereas VSD and PDA cause left atrial hypertrophy. The acquired conditions that cause left atrial hypertrophy are related more to the left side of the heart, the mitral stenosis, mitral regurgitation, left ventricular failure, and left atrial myxoma. So these are the causes of left atrial hypertrophy or P mitrale, biphasic P wave. Congenital causes, VSD and PDA cause left atrial hypertrophy, and in the acquired causes, left side of the heart, mitral stenosis, mitral regurgitation, left ventricular failure, and left atrial myxoma. Then we have P wave with increased amplitude. The P wave with increased amplitude occur in hypokalemia. I couldn't write it here. The hypokalemia increases the P wave and QRS also. Whereas P wave with decreased amplitude occur in hyperkalemia because hyperkalemia is a feature of repolarization. So it decreases the P wave and also hyperkalemia decreases QRS duration and amplitude. Then the other P wave abnormalities are the fibrillary wave, sawtooth, premature atrial contraction, and multifocal atrial tachycardia. P wave, fibrillary or absent, occurs in atrial fibrillation, and it's the fastest heart rate that occurs, and it's the most common cause of irregular rhythm. And this fibrillary rate is 350. Rhythm is regularly irregular, and a P wave is absent or fibrillary, and QRS is contracted because QRS in the if the block is in the is above the bundle of his, then it causes narrow QRS, and if the block is below the bundle of his, then it causes wide complex QRS. And here the P wave is rate is about more than 350, but ventricular rate is also increased because not all the impulses pass through the AV node, but they pass too many impulses pass. So the ventricular rate in atrial fibrillation is also high. So there is ventricular tachycardia also. Another complication of atrial fibrillation is mural thrombus formation that may cause stroke. Then the next is sawtooth P wave, fibrillary flutter wave, sawtooth. Here the heart rate is 240 to 360 beats a minute, so less than the atrial fibrillation, the rate in the atrial fibrillation. The block is 2 is to 1, 3 is to 1, or 4 is to 1. The QRS is regular but may be irregular, but it's also contracted because it's above the bundle of his. Then we have the premature atrial contraction. Here there is a premature beats, and then that arises in the premature atrial contraction here. Premature atrial contraction. So the rate is normal, but the rhythm is irregular. And then next is multifocal atrial tachycardia, where there are multiple foci in the atria. There is rapid and irregular rhythm, see, irregularly irregular rhythm, and there are multiple foci, the P wave that appears, uh, that have the different types of rhythm, very irregular. And the P wave is the characteristic feature that it has a different or variable morphology in the same lead. If you see here, the P wave morphology is different in the same lead. You see? Then this one also P wave morphology different in the P wave. So let's discuss, let's finish it for today here because it's P wave is finished, all the abnormalities, and we did it from starting from the abnormal P wave here. Let's see. Yeah, normal P wave. We discussed the normal P wave in different EKGs and the absent P wave in triple S syndrome, nodal rhythm, idioventricular rhythm, PVCs, VTAC, and ventricular fibrillation. And then let's see, we did PVC and VTAC here, two types, monomorphic, polymorphic, then ventricular fibrillation with fibrillary QRS. So all these conditions, absent P wave, then amplitude, P wave increase, P wave decrease in right atrial and left atrial hypertrophy. In right atrial hypertrophy, tall peak T wave with more voltage and duration, and in the left atrial hypertrophy, we had biphasic P wave with more than 40 millisecond. And the causes of we discussed the causes of P pulmonale and P mitrale. And the P pulmonale causes were ASD, atrial septal defect, cor pulmonale, dilated cardiomyopathy, and Ebstein anomaly. Whereas in left atrial hypertrophy, in the congenital conditions, we have VSD-PDA, the remaining acyanotic conditions, and in acquired condition, we had mitral stenosis, mitral regurgitation, left ventricular failure, and left atrial myxoma. And in P wave with increased amplitude, we had hypokalemia, and with decreased amplitude, we had hyperkalemia. And in the P wave, other P wave, we have fibrillary waves, in atrial fibrillation, sawtooth wave, premature atrial contraction, and multifocal atrial tachycardia, where P wave morphology is variable in the same lead. That's the characteristic feature. So that's it for the day, and we'll come with the QRS complexes in the next session.